Welcome back to RN Toolkit. In this video, we're diving into immune modulators, including interferons, interleukins, colony-stimulating factors, and monoclonal antibodies. You'll learn how these drugs can stimulate or suppress the immune system, their uses in cancer, viral infections, autoimmune diseases, and organ transplants, plus the key nursing priorities for NCLEX and clinical practice. Let's break it down in a simple and clear way so you can master pharmacology with confidence.
The easiest way to think about this whole topic is to picture a control panel for the immune system, kind of like a volume knob on a stereo. Sometimes we need to crank that volume up to help the body fight off things like cancer or a nasty virus. Those are our immune stimulants. Then, other times, we have to turn that volume way down. Think about an organ transplant patient or someone with an autoimmune disease. We need to keep the body from attacking itself or that new organ, and for that we use immune suppressants. So here's our game plan for this briefing. First, we're going to tackle the drugs that boost the system. Then we'll flip over to the ones that calm it down. After that, and this is super important, we'll go over the absolute non-negotiable safety rules you have to live by. And we'll wrap up by looking at how our care has to adapt for our youngest and oldest patients. All right, let's start with the boosters. Immune stimulants are all about giving the body's own defense system a leg up. We're either enhancing its function or restoring it, basically giving it the firepower it needs to take on a specific threat. A major player on this team is the interferon. You can think of these as the body's natural alarm system. When a virus gets into one of your cells, that cell basically screams for help by releasing interferons. It's a warning to all the neighboring cells and a signal that activates the immune troops. And of course, we've figured out how to bottle that process up to create some really powerful drugs. And wow, check out how versatile these are. It's pretty amazing. We're using interferons for certain cancers, like hairy cell leukemia, for chronic viral infections, like Hep B and C, and even for autoimmune conditions like multiple sclerosis. We can even inject them straight into warts to clear them up. So you might be wondering, why do these drugs so often make patients feel like they have a terrible flu? Well, that's actually a key sign that the medication is working. It's kicking off that massive immune and inflammatory response that we want. So your number one job in patient teaching is to set that expectation. Let them know that feeling tired, achy, and nauseous means the drug is doing what it's supposed to do. And that leads us right to our key nursing intervention. Hydration, hydration, hydration. See, interferons get metabolized by the kidneys. By pushing fluids, we help the body excrete the drug more efficiently, and that helps minimize those crummy side effects like dizziness and dry skin. It's such a simple thing, but it has a huge impact on their comfort and safety. Now, building on that, let's look at another class of stimulants, interleukins and colony-stimulating factors. If interferons are the alarm system, you can think of these guys as the dispatchers calling for reinforcements. They're the chemical messengers that tell the bone marrow, hey, we need more troops. Start cranking out more white blood cells, stat. Okay, here is an absolutely critical, non-negotiable safety check. You cannot miss this. A drug called oprelevkin, which is an interleukin, is actually made using E. coli bacteria. What does that mean for you? It means a known allergy to any product made with E. coli is a hard stop. It's a direct contraindication. You have to ask every single time before you administer. Okay, let's totally switch gears now. We've turned the volume up. Now it's time to turn it down. Immune suppressants. These drugs are really the cornerstone of modern organ transplantation and are absolutely vital for managing autoimmune diseases, where the body's defense system has kind of gone rogue. Their job is pretty straightforward, but it's also profound. They intentionally block the immune system. We use them to convince the body not to attack a brand new kidney, or to tell the immune system to stop attacking the body's own joints in something like rheumatoid arthritis. Now, one of the coolest and most sophisticated types of suppressants are monoclonal antibodies. The absolute best way to think of these is like smart bombs. They are engineered with incredible precision to find and attach to one very specific target on one type of cell, and they ignore everything else. For them to work, it has to be a perfect match between that antibody and its target. And here are two perfect examples of how that works. You have palivizumab. It's a smart bomb aimed squarely at the RSV virus to protect high-risk babies. Then you have alemtuzumab, and this one comes with a huge safety alert. There is a serious risk of a major hypersensitivity reaction if a patient gets it more than once. So if you ever see an order for a second dose, that is your cue to stop, pick up the phone, and confirm that order directly with the provider. No exceptions. So let's do a quick dose calc, because you will be doing this. Dosing for a lot of these smart bombs is super specific to the patient. usually based on their body's surface area, or BSA. So let's say the order is for 400 milligrams per meter squared. Your patient's BSA is 1.85 meters squared. You just multiply those two numbers together and you get your dose, 740 milligrams. It's a simple but absolutely vital calculation. Okay, let's stop for a second. We've now reached what is, without a doubt, the most important part of this entire briefing. These are the non-negotiables, always and never safety rules for any patient on these drugs, especially the suppressants. I want you to really think about this for a moment. When you're caring for a patient whose natural defenses, their army, have been intentionally weakened, what is the one thing that rises above everything else? What is your number one priority? It is always, always, always protecting them from infection. A simple cold that might knock you out for a day could be a life-threatening event for them. This is your prime directive. It means perfect hand hygiene. It means screening every visitor for so much as a sniffle. It means creating a safe bubble around your patient. This is everything. And that prime directive carries right on through to your discharge teaching. Number one, they absolutely must avoid crowds and anyone who's sick, period. Number two, they need to use barrier contraceptives. Why? Because many of these drugs mess with the liver, which can make birth control pills totally ineffective. And number three, they cannot take any over-the-counter drug without talking to a pharmacist first. The risk of a dangerous interaction is just too high. Okay, let's wrap up by quickly touching on how our care changes when we're talking about kids versus our older adults. Because, as we all know, a child is not just a little adult, and our geriatric patients have their own unique set of challenges. Now, here's something that might surprise you when it comes to kids. They often need larger doses of certain drugs, like cyclosporine, than adults do. Their metabolism is just in overdrive. We also have to be super aware of injury risk. Think about a 10-year-old on a soccer team who's immunosuppressed. That's a different level of concern. Then for our older adults, it's all about their baseline. Dosing has to be carefully calculated based on their kidney and liver function, and we have to watch them like hawks for any sign of infection because their immune system is already less robust to begin with. So when you boil it all down, what's your role in all this? You're not just a person giving a pill or an IV. You are a vigilant guardian. Your sharp assessment skills and your proactive, clear teaching, that is the firewall that stands between a successful treatment and a really serious, harmful event. And that kind of leaves us with one final thought to chew on. We are getting scarily good at fine-tuning the body's most complex system. As that power continues to grow, what do you think is next? What's the next great frontier that immunotherapy is going to conquer? Thanks for joining me.